So let's go back to reviewing our anatomy, the stuff that I showed you on the model. I'm going to go over it again on our live patient. So you're going to find your occipital protuberance. That's that bump at the top right here. You can feel sometimes that occipital ridge that cruises down from it, and then your mastoid process right here. And so when you make that line from the occipital protuberance to the mastoid, that's the line that we're going to be cutting into thirds. The proximal 1/3 and then the distal 2/3. And the proximal 1/3 is where your lesser occipital nerve is going to come out, and that's going to innervate the scalp, the lower scalp and the posterior neck. And then the greater occipital nerve is going to do from the scalp up to the vortex in this area. I like to use this block for tension headaches. I'll often sometimes also use it for my migraine headaches. When we're talking about what's the data, what's the most robust for, this one doesn't have a specific headache where we have really great data, but I've had good effect for both of those types of headaches. So what I'll do is I'll just prep my area. I'll keep my finger on my mastoid process and the occipital protuberance, find where my nerve is coming out. I'll clean that area with my alcohol. Now, remember, the patient has a lot of hair here, so no biggie. Just spread it out and clean it up with your alcohol swab where you're going to inject. I'm also not wearing gloves for this procedure. Technically, I normally would be wearing gloves, but for learning purposes, we're going to go sans glove. Once you've found your spot, you want to grab your needle. I have my anesthetic. This is the greater occipital nerve. And when I go in, you just want to go under and make a little bit of a skin wheel, pull back. Make sure you're not in any vasculature, little skin wheel. And then the bone is really superficial. So once I get in, I tuck it in, I hit the bone, and then I just inject 1 cc of local anesthetic. The next thing I'll do is I'll pull out and I'll fan it to the right. Do the same thing, pull back, inject a little bit more, and then fan it to the left. And now what you've done is you've really created an area where this nerve cruises up in a single line, and then by fanning out, you've increased your chances of hitting that nerve before it goes up into the scalp. Alternatively, remember we talked about palpating the occipital artery. Remember that nerve is just medial to that. You can do that as well. You feel that artery in the same general area that you want. If you want to be a little more pinpoint and a little more precise, you just go just medial to that, making sure that you're not injecting into the artery, obviously. That brings me to another point is when you're using your anesthetic, this is all going to be without epi. There's no need to have epinephrine inside it with your lidocaine or your bupivacaine. People will also sometimes add a steroid to this for longer lasting anti-inflammation for headaches. We don't have any good data on that, and so I don't routinely use that. I don't usually have access to steroids easily in the clinical area that I work.